Good morning, everyone, and welcome to our webinar, What Patients Say About Primary Care, Findings from the OECD's Patient-Reported Indicator Service, PaRIS. My name is Sebastian Bauhoff, and I'm the Principal Health Economist in the Health, Nutrition, and Population Division at the IDB, and it's a pleasure to welcome all of you today. Before we begin, let me remind you that we have simultaneous interpretation in English, Spanish, and Portuguese, so please feel free to select the language of your choice. Today, we are joined by a distinguished panel: Fred Guarnez, the Deputy Head of the Health Division at OECD, James Fitzgerald, Director of Health Systems and Services at PAHO, and Patricia Garcia, Professor at Universidad Peruana Cayetano Heredia. Later on, we will have a Q&A session, which will be moderated by Javier Guzman, Division Chief of the Health, Nutrition, and Population Division here at the IDB. We encourage you to leave your questions and comments using the Q&A button below at any time during the presentation and reflections. Today, we will have a very important conversation, and it starts with a very simple but powerful questions. What do patients say about the care that they receive and the experiences that they have? For those of us working on strengthening health systems, this is really an essential question. Understanding how people experience primary care, what matters to them, what gaps remain is a key to shaping policies to achieve high-quality health systems. PaRIS is a large and innovative effort to systematically understand those patient experiences. So with that, it's my pleasure to welcome Federico, who leads the PaRIS International Survey and oversees the OECD's work on people-centered health systems, primary care, and health system performance across the OECD and partner countries, as well as the regional work in Latin America. Before joining the OECD, Federico spent nearly a decade at the Inter-American Development Bank with us, where he led a large portfolio of health sector loans and technical cooperation projects across the region, and also advanced knowledge initiatives, including, and most notably, the IDB book on From the Patient's Experiences, which is still one of the most comprehensive work on people-centered care in Latin America and the Caribbean. Fred's research has been published in the British Medical Journal, Health Affairs plus Medicine, and the American Journal of Public Health. He holds a PhD in public administration from New York University and has contributed to 2 Lancet commissions on high quality and resilient health systems. With that, Fred, welcome, and over to you.
Thank you. Thank you very much, Seb. Thank you. It's a pleasure to be here today and with such distinguished colleagues in the panel with Javier Guzman. Thank you so much for the invitation to join this session at the IDB, and Patti Garcia and James Fitzgerald. This is a topic that's very dear to my heart, and it's, of course, a great pleasure to talk about this today. Primary care, patient-centeredness, what matters to people, and the results that actually healthcare generates to people. I'm gonna present, of course, there's a long OECD report with the results of the PaRIS survey, but I really want to focus on what I think is the most important key findings about the research and then the report that we published. Next slide, please, Marisol. So I think that I would like to start by saying that PaRIS is not something that appears out of nowhere. It is embedded in a much broader movement about how we measure the performance of health systems. So in 2017, there was a big ministerial meeting here at the OECD, and the health ministers, they gave us a mandate, and they said, look, we really want to change the way we assess the performance of the health systems, and we want to put people at the center of that. So that represents an evolution of nearly a century or even more about what are the key metrics of health outcomes that we use to assess health systems, starting from deaths. So we're measuring life expectancy, we're measuring mortality. That's information that comes from death registries. And then on to diseases. Well, we actually want to measure the prevalence and the incidence of the diseases. This is a medical or clinical perspective, and that comes from administrative data, from clinical data. And then on, well, it's not enough actually to measure whether people are dying too early or whether they have a disease. We want to measure how the health system deals with the disabilities. And then there are instruments for that. We can use DALYs, we can use QALYs, we can use instruments like the SF36 questionnaire. And this comes from registries and from surveys. But really, above all, what matters to people is not only how long they live, but how well they live. So, in that sense, it's very important to try to get to the things that matter most to the patients, to the carers, to the families, to the populations. Well-being, function, absence of pain, quality of life. Those are patient-reported things. And there's no other way to get to those unless asking the patients themselves. So this is something that we need to get directly from the patient's perspective. Next slide, please. And I think this is, Seb mentioned this in the beginning. Perhaps the thing, if you had to ask me, what is the one thing that I'm most proud of the time when I was in the IDB? And I would certainly highlight this book from the patient's perspective. This book was published in 2018. Of course, I'm proud of everything that I did at the IDB. I had a great time there. But this book has really, a place close to my heart. This book was the result of surveys that we applied in 6 countries in Latin America and the Caribbean, asking patients. It was something that was following the Commonwealth Fund survey questionnaire, that asking directly to the population several aspects about the utilization and about the results they're getting from the healthcare systems. So I trace a direct line from that book to the report that we published just in February of this year, Does Healthcare Deliver? And this is the book that reported the results from the first round of the patient-reported indicator survey, PaRIS. Right? So this was a report that we really focused on, what's the goal of healthcare system? It's to improve well-being, right? But how do we know whether healthcare is actually successful in doing that? So we spend a lot of time, and you can get a lot of OECD publications like Health at a Glance that report how many doctors countries have, how many hospital beds, how many nurses, how much money spent on it, or the processes such as consultations, surgeries, and etc. But we report very little about what people really get from the healthcare systems. So PaRIS comes to fill in this critical gap into the experiences and the outcomes of healthcare directly from the patients themselves. So it's very interesting because from the PaRIS survey, we really wanted to capture the voice of the patients, right? I think that this is some of the things that are most difficult to find in the literature. So that's why we are so proud of getting this contribution. Next slide, please. So PaRIS is the largest international survey of people living with chronic condition. We interviewed 107,000 primary care users who are aged 45 years and older. We interviewed the 1,800 primary care practices where these patients receive care, and that was done in 19 countries for the first wave. The first wave data collection will happen mostly in 2024. Those were questionnaires that were submitted either through an online mechanism or by telephone. Of course, there was extensive preparation for people to get to that point. And the entire sampling was done in a multi-level methodology in which we sampled the primary care practices and then we sampled the patients that use this primary care practice. So it's a multi-level survey in which patients are clustered across providers and across countries. And why did we do that? We did that because we wanted to know really not only what people were getting from the healthcare systems, but also how to get it, right? What were the practices? What were the things that the primary care was doing that were most successful in achieving the important results? The development of this entire survey was a collective endeavor that included patients, professionals, experts. So we had specific panels for each one of these groups and the policymakers that congregate in the OECD Health Committee. We have published extensively the methodological aspects of the development of this. So even in in academic journals. So it was really a method that we wanted to capture what mattered most without compromising the rigor and the scientific precision in while we're doing that. So why did we do people 45 years and older? Because we really wanted the people, we're focused on the chronic conditions, right? So we wanted to capture the problems that are most important and most prevalent in OECD countries. And from the years 45 years and older, this was more likely to happen. I wanted just to give you a parallel. You probably know another OECD survey called PISA. PISA is the OECD education survey that's done when students are 15 years old. And PISA really wants to measure what students are learning. Not what's being taught, but what they are learning. So PaRIS wants to do the same thing, not how many treatments and what kind of procedures are done to patients, but what they are getting from their health system. So that's why we say that PaRIS, in a way, is sort of the PISA for healthcare. And what did we get? Next slide, please. We found that among this population of 45 years older, and the only condition for eligibility was that people had used primary care at least once in the previous 6 months. Within this group, we found that 82% had at least one chronic condition. 52% had 2 or more chronic conditions. 27% had 3 or more chronic conditions. So the majority of people 45 years old were already with at least 2 chronic conditions. Dealing with multimorbidity is already the day-to-day business of primary care, with the innumerable implications of that, the complexity of management, because among the people who live with multiple chronic conditions, 70% take at least 3 medications daily. More than a third takes 4 medications daily, with all of the implications that has from the provision itself, right? How to actually make sure that those people get those medications they need, but also how they manage to follow the treatments according to what's been specified to them, and also how that's reviewed periodically. So it's really important to put the people really at the core of that, because they are the ones who are going to be following up of their treatments. Next slide. And the conditions that were most prevalent were hypertension, of course, then musculoskeletal and cardiovascular conditions. Here is, people could actually select many conditions, so it does not add up to 100. But here there's the result, the prevalence are separated by condition among men and women. And what we found that men were more likely to report conditions like high blood pressure, cardiovascular disease, diabetes, conditions that were more lethal and had a much higher lethality rate. While women, they were more likely to report conditions such as arthritis, depression and anxiety, and neurological conditions that are not necessarily lethal, but that are very debilitating and reduce quality of life. And that book is going to have some important implications on the results that we observed. Next slide, please. So then we collect, the PaRIS survey is a questionnaire of 100 questions, takes 25 minutes for people to answer. And of course, we have a mass of data. But we really wanted to boil down to 5 patient-reported outcome measures and 5 patient-reported experience measures that really capture the performance of the health systems from the patient perspective. The outcome measures are physical health, mental health, social functioning, well-being, and general health. Physical and mental health are PROMIS scales, scores. Those are scales of 4 questions each. Social functioning is just 1 question. Well-being is the WHO 5, a battery of 5 questions, and general health is 1 question only. And this radar plot does not show the name of the countries, but it shows the country that had the highest score in each of those, the lowest score in each of those, and the average of the OECD. And we found that among the PROMs, the patient-reported outcome measures, there was less dispersion for the majority of indicators than from the PRAMs. But still, I mean, there was important variation across countries in all of those measures. On the other side, on the patient-reported experience measures, we selected 5 key indicators. One was the trust in the healthcare system. It was a direct question asked to people. The second one was the experience, quality of care. It was one question only. The third one was the person-centeredness of care. That's a battery of 8 questions, PC3 EQ, that produces a score that ranges from 0 to 24, but that includes things to the extent that that healthcare professionals discuss what's important for the patient, involve them in decisions, that there's no need to repeat information that was in the records, that when the person is seen, they feel that they are considered as a whole person and not a collection of diseases or symptoms. So that generates a score of person-centeredness of care. The following one is the experience coordination of care. That's a battery of 5 questions that generates a rank that includes whether care is organized in a way that works for the patient, whether there's a single point of contact for the majority of the needs, whether the patient has a care plan taking account most of their needs. So that again produces a score, and then we reported the results there. And then the other one is the confidence in self-management. Because it's a question that's asked to the person to how confident that they are that they can manage their own health and their own symptoms. And the PRAMs were actually some of the things that had the highest spread and the highest variation, especially in the confidence to self-management, ranging from 24% to 92% of the people who said that they're confident. Also in experience coordination of care, there was a hard 60 percentage points spread between the best and worst performers, and also trust in the healthcare system. So if you go to report, you'll find detailed data about how each country scored on these indicators. Next slide, please. But here is just a very quick snapshot of, where I said that there were 10 indicators. And then here is saying, well, for each country, how many indicators are below the OECD average, how many indicators are close to the OECD average, and how many indicators are above the OECD average. So Switzerland was the country that performed the best, with 9 of the key indicators above the OECD average, and 1 close to the average. The second one was Canada. And of course, I think Canada is a more interesting example than Switzerland because, of course, Switzerland spends a lot on healthcare. So Canada was a very interesting, outcome. It's not a surprise. They have a strong primary care-based system, but then they were the country that had 5 indicators above the average, 4 close to the average, and 1 below. The countries that had the worst performance were Wales and Portugal. Portugal was the one that they had 2 indicators close to the average and 8 below the average. And then you see 2 countries in the bottom, really separated. And they are separated for a reason. In Italy deviated itself from the methodology of the survey, so they used a different eligibility criteria. Because remember that I said the eligibility was only having had used primary care clinic in the previous 6 months. Italy actually went directly to a registry of people with chronic conditions. So that it needs to be, it's a population that tends to be sicker than the general population of Italy, probably. And then the other surprise is the United States, that every other international survey, like the Commonwealth Fund survey, says, look, the United States performed really, really poorly in those comparative surveys. And here, they're actually really good, right? With 6 they would actually be the second country just behind Switzerland. But, and there's a big but, there's a reason for that. And the reason is that the United States was not able to sample the population from 45 plus. They sampled the population from 65 plus because PaRIS was implemented as a module of the Medicare Current Beneficiary Survey. So it happens that the United States sample a portion of their population that has universal health coverage, right? So the population 65 plus with Medicare. So, the message from the United States is that care can be really good if only you can afford it. Next slide, please. So some other indicators, some other results that we get from the analysis of countries. Sorry that the legends get a bit mixed up there, but I think you can get the picture. So this graph shows the percentage of people, of patients with at least one chronic condition that have good social functioning. It's like a measure of social health, how well you carry out your usual social activities and roles. And then what happens is that for every country, you see that for every additional chronic condition, reduces the social functioning of people. Look at Wales. For people with one chronic condition, around 85% of people have good social function. If you have three or more chronic conditions, this is reduced to 55%. So there is a big spread in there. It's not the case in every country. In every country, for every additional chronic condition, your social functioning is reduced, but the amount varies by country. So the idea is that how good of a job countries are doing in keeping those people with multiple chronic conditions also feeling in good health, in good well-being, in good social functioning, and that's what the goal that we're looking for. Next slide, please. Another finding that we have is that it was not a big surprise, but that it was a good corroboration of a hypothesis of other that we have seen in the literature is that women consistently report worse physical and mental health than men. This is a graph that compares the PaRIS physical and mental health scores. It's a scale with a mean of 50 and a standard deviation of 10. And there's a cutoff point for being in good health. And then in every country, the difference of the scores of women minus men is always negative. There's no reason why it should not be positive. Maybe women could have had better mental and physical health than men, but that's not happening in no countries. And in some countries, this is particularly striking, the differences in Portugal, in Saudi Arabia, in Spain, the difference in physical health was quite large in disfavor of women. So this is the gender health paradox, right? Men live much less, fewer years than women, but they live in worse. But women live in worse health than men. So women live longer, but women live in worse health. Next slide. So, of course, we're also an economic organization. Spending more does not necessarily mean better healthcare. So here we have, if you go to, this is a quadrant chart that goes on the vertical on experience quality of care and the horizontal health spending per capita. So if we make a line from the Czech Republic to Canada, Belgium, Australia, Switzerland, that's the CH over there, and even the United States, all of these countries have pretty much the same levels of satisfaction with the quality of care. Nearly 95% of the people in all of these countries are reporting good quality of care. But the level of expenditure is very different, right? So if we take Czech Republic as the reference, Canada, Belgium, and Australia spend 50% more than the Czech Republic. Switzerland spends twice as more as the Czech Republic, and the United States spends 3 times as more as the Czech Republic. So I think the Czech Republic is a country that would be interesting to have a look if you would like to explore some interesting practices. Next slide, please. So, but then another part of the report, we moved into what are the things that health systems can do? How can the health systems provide what matters to patients? And then we came up with this 3 T's: time, trouble-free care, and tailored care. Next slide. And the next one. Yeah. So starting with time. So from other analysis that we did, people tend to report better quality of care when more time is scheduled for consultations. And yet, in more than half of the countries, the majority of people are seen in primary care practices with scheduled consultation times less than 15 minutes, right? So that's a quite interesting finding that most of the countries are scheduling very short times for the practice to see their patients. And then some countries, even countries that have a strong tradition of primary care, such as Netherlands and Spain, the vast majority of the patients are seen in a practice where less than 15 minutes is scheduled for the patients. That's very different, like in Norway and Portugal, where the vast majority of people are seen in a practice that schedules more time for their patients. Next slide. We also see that people tend to report better quality of care when they have been with the same professional for longer. And yet, in more than half of the countries, more than 40% of the people have been with the same professionals for less than 50 years. Look at Spain again. In Spain, it's also one of the countries that has this lowest proportion of people. It's not as dramatic as the consultation time, but the lowest proportion of people that have been more than 5 years with a professional. And look at Czechia, that I said was an interesting example. We have 75% of the patients in Czechia have been more than 5 years with the same healthcare professional. So that differences in the rotation of professions can explain many interesting things. Next one, moving to trouble-free and safe care. Next one. We found that the adverse events in primary care are linked to lower trust in the healthcare systems and in the healthcare professionals. So here we have the patients who trust the healthcare system. So on average, 70% of the people trust the healthcare system when they say, look, nothing ever went wrong in primary care. And when wrong mean you got the wrong medication, you got a wrong diagnosis, you went too long without a diagnosis. But when something went wrong, the trust that people have in the healthcare system drops by nearly 30 percentage points, right? So if you want to have people trust in the health system, so of course you need to make sure that they are not going through major problems in primary care. Next one. And here's a very concrete example that the needing to repeat health information is linked to lower trust in healthcare professionals. First one I said was about the trust in the health system. This one is about trust in the healthcare professionals. So, and then the need to repeat information that should have been in your healthcare records is really an interesting thermometer of the trust that people have in that professional being eroded. Right? So when people say, look, I never needed to repeat anything that should have been in my records, the trust is above 80%. You know, people trust in their healthcare professionals. When they say that they had to repeat something, this trust level is reduced by at least 20 percentage points in the red dots over there. So that's another very important aspect. And finally, tailored care. Tailored means specific and customized to the patient. I'm already over time, apologize for that. So, but here I just wanted to say that patients report better well-being when care is tailored to their needs. This is the percentage of people who are in good well-being. And then the dots on the top saying, well, when the person receives care that's centered, high level of person-centeredness. So when the care is not centered on their needs, on average, we see that the level of well-being is reduced in all countries, which is in most cases sufficient to cross the threshold for being in good well-being, which is 50. Sorry, the red line is in the wrong place there. Next one, and I'm almost finishing. So, and then we did a multivariate regression, throwing a bunch of things, saying, okay, so what are the things that the professionals do that really actually increase the scores of person-centeredness report by their patients? And then, this is a regression at the patient level with person-centeredness as the dependent variable. And then we found that professionals spending enough time and giving easy to understand instructions were by far the most important elements. Providing written instructions, having video consultations, and accessing medical records online, it was also important. But it's so interesting how the longer consultation time and clearer communication is clearly what's the most important, followed by the aspect of digitalization. Next slide. And then you see across OECD countries, there's a lot of variation of how people are reporting their experience of primary care, right? So in some countries, 100% of the patients say that they were managed in a practice that can exchange medical records electronically, right? They're interoperable electronic records. In some other countries, is almost zero, like 5% of patients. Again, similarly, the patients managing practices well prepared to coordinate care. In some countries, all practices report well. Yes, we are well prepared to report, coordinate care, and in others, it's nearly zero. And patients receive enough support to manage their own health. Again, so in some countries, 80% of the patients receive good support to manage their own health, and 40% of the people in some countries, it's only 40%. So moving on to my last slide, to sum up the title of the report, does healthcare deliver? Well, the answer is yes, yes, it does. People with chronic conditions do report better physical and mental health and well-being when the healthcare is centered on their needs. But, and there's a big but, people with multiple chronic conditions need better support. Digital technology can play a bigger and more focused role, and continuing to listen to patients is key to transform healthcare. Next slide. And that's the last one, just with a QR code that you can download the report, but I'm sure that the IDB is also going to circulate the report afterwards. Thank you so much.
Oh, thank you so much, Fred, for this presentation. Truly insightful, and congratulations again on this effort. I think it's a very innovative and also complex design, including the ability to link by design the patients and providers. Really a massive effort. I have a lot of things to say, but I'll hold my questions. And just to say for our audience, please remember to put any questions you might have under the Q&A button. And our presenters, if you have a moment and you want to answer already in the Q&A chat, please go ahead and do that as well. But let me turn to our next panelist here, James Fitzgerald, the Director of Health Systems and Services at PAHO, who will share his and PAHO's perspective on these topics. By way of introduction, James leads PAHO's work on health policy, governance, primary healthcare, workforce development, health financing, access to medicines and technologies in the Americas. He has more than 25 years of experiences at PAHO and the WHO, including assignments in Haiti and Brazil, and he has played a key role in advancing universal health coverage, strengthening health systems resilience, and overseeing regional initiatives. He's also our critical counterpart for the Alliance of Primary Healthcare, which I'm sure we'll talk about in a moment. James holds a PhD in pharmaceutical sciences from Trinity College Dublin and has authored numerous publications in this field. Welcome, James. The floor is yours.
Thanks so much, Sebastian. Congratulations to you, also to the OECD for hosting this really important event. And Federico, congratulations on the study. It's really fascinating to see how the analysis has really garnered a systematic review of the context of quality and perceptions within OECD countries. I have four, I think points that I'd like to raise around some of this, really as it relates also to, of course, our work in the Pan American Health region, which goes from Canada, United States, to, of course, Argentina and Chile, some of our countries also being OECD members. I think the first comment I'd like to make really is a recognition of the importance of these surveys. It's really fantastic to see how a systematic approach can be applied across multiple countries, standardized through a set of core indicators that have been discussed, analyzed, and reviewed to generate the data that is really necessary for policymakers to move forward in taking action and decisions to improve quality of care. And I think this is something that, unfortunately, in many countries, particularly in the region of the Americas, we have not managed to, as of yet, to be able to standardize or even institutionalize processes around patient surveys. In a report on progress to improve quality of care within health systems in the Americas, published in 2023, I believe, only 16 of 23 countries that we surveyed reported having, and I quote, an inspection, auditing, or feedback mechanism in place. And of course, across these 16 countries, the processes are non-standardized. So I think that's really one thing that we really need to take from this work, the importance of really working with countries in recognizing, first of all, the importance of carrying out patient surveys, and secondly, generating the data and the standardization process that are required. I think the second point I wanted to make was really around an issue that I think many countries in the Americas face with regard to quality. Um, and it really relates to an issue I think that is probably more macro than meso or micro in terms of service delivery. And it relates to the issue of coverage and access. So some of the more, I suppose, strategic political decisions that need to be taken to ensure universal coverage and universal access to health through structured, organized processes within health systems that thereafter ensure the universality that is required within a health system. In a report we published in December of 2024 on advances towards the achievement of universal health coverage in the Americas, we reported that across the region, 38.5% of people continue to report unmet health needs. And so as we talk about quality and perceptions, if we cannot even meet the demands of people where they are actually living, well, then we have a fundamental problem within our health systems that need to be addressed relating to effective coverage and effective access. And of course, this is exacerbated within the region of the Americas by enormous inequities that persist across socioeconomic groups, territories, populations, in accordance with the social determinants of health. So this issue of effective coverage and access as a perceived in patient surveys, I think, is really an important element. And part of that is really the financing component that you mentioned. Within that unmet needs, we see that 8% of people are reporting catastrophic expenditure within the region of the Americas. The third point I think I really wanted to highlight was, and it's something that I think the survey really pulled out, is the central role of primary health care in ensuring quality. The foundational premise of an organized, structured health system is, as you well put, a strong foundational, highly resolutive primary care that really responds to the needs, not the demands or not the service offer, but the needs of the population actually where they live. And again, I think we in the region of the Americas face considerable challenges. If we look at some of our, I suppose, results framework indicators within PAHO, one of them is avoidable hospitalizations, which is, I suppose, a proxy for the effectiveness and resolution capacity of primary care. And in the report that we published again in 2023, we noted that now one single country in the region of the Americas has reduced avoidable hospitalizations by that target that the countries themselves agreed on, which was essentially 10% over the last 5 years. And so we have a challenge. And we understand that, as countries continue to expand coverage and access, while there will be greater demand for secondary, tertiary care, however, much of that is avoidable if we shift it down into the primary care setting. Aligned with this also are the barriers to access. And in the data that we look, the data that we have in the Americas indicates that, yes, financial barriers are important, but what seems to be really driving barriers to access care at the moment is organizational barriers. And this speaks to an issue that you very much highlighted, the organizational structures and mechanisms that need to be put in place to ensure continuity of care throughout the system. And we now have the added both opportunity and challenge associated with the digitization and digital transformation of the health system. So that this is just such an enormous and important area of work that I think we can all work on. Final point then I think really speaks to the issue of governance. Again, coming back how we institutionalize such assessments, how we can feed in data and results into policymakers so that they can take action, not just at the national level, but at the local level, where I'm sure we'll see differentiated significant differences in outcomes also in your data if we looked at it in terms of territorial levels within OECD countries. and then how we can guide countries to really move forward in the development of national plans. Only 15 countries in the Americas have national plans for quality of care. This is a constant challenge that we face in moving countries forward to addressing the issue, not just of coverage, of access, but also quality. And so central to this is also the challenges that countries face in the health workforce, interprofessional care, interprofessional education, and the accreditation processes, including the licensing, the renewals of licenses, and the professional associations that need to be brought to the table. So once again, congratulations. I think an excellent report, really aligns with much of what we're seeing. We know that OECD countries are somewhat more advanced along this road, but I think there's much to be taken from it as we look at the region of the Americas more broadly. Thanks so much.
Thank you so much, James, for sharing this perspective. And I would like now to turn to Patricia Garcia, who's a professor at the Universidad Peruana Cayetano Heredia, to hear her perspective from her experience with policy and research also on health, high-quality health systems. Just briefly, Dr. Garcia is a professor and former dean of the School of Public Health at the university and a member of the U.S. National Academy of Medicine. She's also a former Minister of Health of Peru and former chief of the National Institute of Health, where she also held an affiliate professorship at the University of Washington and Tulane University. She currently holds that affiliation. Apologies. She also served on several Lancet commissions, including those on diagnostics, medical oxygen, implementation research, and chairs the Commission on Cancer and Health Systems, which I think is particularly relevant also to this conversation. She's recognized as a leader in global health, and her experience spans implementation and health systems research, reproductive health, STI, HIV diagnostics, digital health, and HPV cervical cancer. Thank you again for joining us, Patty, and over to you.
Thank you so much for the invitation. And it is a pleasure to be here and to say hello to dear friends like Federico. Federico, congratulations really for the work that you are doing, that you started to do while you were at the IDB and here in Peru, and what you are continue doing at other parts of the world. So I have some reflections and some comments regarding what you have said. So let me start. First of all, what we do not measure, we cannot improve, okay? And that's a critical thing. Having a standardized instrument that allows comparison across countries is extremely valuable, okay? Second thing is that measuring care at the primary care level is essential. We are talking about the importance of strengthening primary care. So if we're going to do that, we need to have ways of measuring what happens there. Patient-reported outcomes, like the ones that you have chosen to present and that you have been able to collect through this instrument, like physical, mental, and general health, social functioning, well-being, and also patient-reported experiences. So outcomes and experiences like quality, coordination, confidence in self-management, person-centered care, and trust in the system are practical, okay? But even if they are challenging to collect. But the question is, what comes next? Once we have this information, how will we use it to drive improvement? And these instruments allowed us to monitor also change and assess whether interventions are actually making a difference. So now we have the baseline and we need to think, what are we going to be doing to improve? And we can still use the instruments to see if this is effective. One limitation that I see is that, unfortunately, with this very focused view at the level of the primary care centers, we are not assessing how the whole system functions. And for chronic conditions, for example, primary care is only one piece. Referral systems and continuity of care are equally critical. And in one of the figures that you show, one of the aspects that has the lowest evaluation is if they have experienced coordination. And that coordination probably had to do coordination within the center, but probably also coordination that had to do with referrals or other things that they need. Another issue that arises to me as something that we need to think that could be important to understand is whose voices are we really hearing? Okay, we are mostly capturing the voices of patients already inside health facilities where they may feel constrained or worried about saying the full truth, creating desirability bias. So in other words, probably whatever we are seeing, it's the minimum of what is wrong, okay? Because they may, once they are at the health center and once people receive care, they may not feel fully capable or comfortable to say all the things that they need to say. And we also need to hear from people who do not reach the system. So those are the people, not the patients. Those who cannot get appointments or wait so long that they turn to pharmacies, traditional healers, or informal providers. This may not happen in high-income countries, but it happens in low, middle-income countries or in regions like the Latin American region. This is something like other surveys, like the ones that we have been working on, like the People's Voice Survey, has highlighted very powerfully. I really appreciate the concept, and I really like the concept of the 3 T's: time, trouble-free care, and tailored care. But you know, time also means the time people spend waiting to get an appointment, which in many countries, including low middle income countries and even places like Canada. I was in Canada at a taxi and I heard the news and people were complaining about that sometimes they never get the appointments that they need. So this is a major barrier. And I think we all would like to hear what is happening there. And sometimes we don't ask that to the patients once they are inside the centers. Finally, most results presented are coming from high-income countries. It's true. I think it's time also to gather perspectives from different populations globally. One of the questions that was brought by somebody is what happened with people from rural areas, right? And that's more common in parts of the world like ours, like in Latin America and maybe Africa. In some surveys, again, from the People's Voice survey, there is a consistent message because you were saying at the end that health systems probably were delivering, where what we have seen is that systems are not delivering as they should. And both health outcomes and experiences outcomes are poor in our side. But listening, completely agree with you, listening to people is essential. And I'm talking about people, not only patients. But more importantly, we must use their feedback to co-design improvements. So I think at this point, we should start working on co-design with communities and then measure again to ensure that we are truly advancing. So I think you are touching exactly what we need. We need to measure, but we need also to start using these numbers. I mean, those numbers that you are showing to start talking with countries, and we need to start doing things. Even with chronic diseases, right? Once we know what happens at this level, if we want to improve things, let's think that chronic diseases cannot be only measured by cross-sectional surveys. We need to start thinking what happens longitudinally and maybe using instruments like electronic cohorts of chronic hypertension, chronic diseases, might be things that we could use. And then ensure that we are truly advancing. So thank you so much for the work that you're doing. Thank you for bringing all these things to start pushing countries to do something different. And thank you, IDB, for inviting me.
Thank you so much, Patti, for your kind reflections. We will now move on to a Q&A session. If you have questions and haven't done so yet, please feel free to add them to the Q&A box, and to our participants, panelists, please feel free to answer questions you might see under the Q&A button at the bottom of your screen. It's my pleasure to welcome Javier Guzman, who's our Division Chief in the Health, Nutrition, and Population Division. In the interest of time, I'll skip the bio, but just to say thank you, Javier, for joining this conversation, for leading this part. Over to you.
Thank you, Seb, and thank you to Fred, James, and Patti for being here, and for you all to stay with us. A fascinating conversation, and I'm sorry we don't have a lot of time for all the relevant questions that we've seen in the Q&A. So I'll start with a few key questions for our panelists. Fred, the first one, and this one is for you, is about the future. So we look at PISA, we know how sustainable that effort is at the moment, and we know that PaRIS Round 2 is expanding globally. So what is the future of PaRIS, and how do you see the Latin America region within that expansion? What would it take to get the countries to join, and do you think is beneficial for the efforts that we are taking place to improve primary care performance? Over to you, Fred. Thank you.
Absolutely, Javier. I think, my biggest frustration in my career in the OECD was not getting any Latin American and the Caribbean country into PaRIS, right? So we do have Canada and the United States, which is PAHO members, but no LAC countries. So I'm very frustrated about this. But the good news is that we have two countries that have already formally sent the letters of expressions of interest to join the next round, which are Brazil and Peru. Right, so I really hope to get your support, to encourage other countries to join. Sometimes the barriers are financial because, countries have to finance their own data collection and also the shared costs. Maybe the IDB can be a partner in that. We can discuss something. And other barriers are really, the organizational, and then putting these things into the topics that are important for the countries. But let me say this. Two of the countries were the first signers of this. Look, we really want to be in the second round, were Portugal and Italy, the two countries that had really bad scores in PaRIS. So that's very interesting. Portugal was the country that had the worst performance on PISA on the first round, just only better than Mexico. And then for 20 years, every new round of PISA, they improved their scores. They already are above the OECD average. And there was a time when nobody could make any conversation in Portugal without saying the PISA scores show that, right? We don't want to be the only one, but we want to be part of this discussion and connecting to really what matters to us is the feedback and the policy action that goes together with it. So I hope we can all be part of this conversation for the next time around. And I hope there will be many Latin American countries, Javier.
Well, we hope so too. And we also want to be part of that change. So James, talking about the region, it's been nearly 2 years since PAHO, the World Bank, and the IDB co-launched the Alliance for Primary Healthcare in the Americas to accelerate primary healthcare investment and innovation and implementation across the region. How do you see these patient-reported outcome and experience measurements like PaRIS as part of the Alliance? Do you think there's a role for this to play there?
That's a great question, Javier. Thanks for that. Yeah, so the Alliance for Primary Healthcare now is really quite operational in 5 countries, with another 7 or 8 having more informal mechanisms of coordination. The idea here is really that through the Ministries of Health, they establish formal processes coordinating across the IDB, the World Bank, and PAHO to really integrate the investments based on primary healthcare. Just this morning, actually, we had a meeting with the Dominican Republic, where our director, Dr. Jarbas Barbosa, participated with the Minister of Health, chairing the meeting of the Alliance in the Dominican Republic, whereby the technical consensus document around integrated health service delivery was presented, showing how this document is really carrying out an analysis of the maturity of health services networks in the Dominican Republic across multiple territories. And what was really interesting, Javier, in that presentation was that as part of the maturity assessment of health service networks in Dominican Republic, they also presented data from patient surveys on primary health care. So as you were just saying that, I was beginning to think, well, wouldn't this be interesting if we could actually link some of our work around the Alliance on Integrated Health Service Delivery and link in then the patient care surveys as in a more standardized format with the work of the Alliance, and begin to standardize and use the Alliance to actually expand this work into other countries. So that's certainly an area I think that we have, an opportunity that we have for discussion with you and Federico, and of course our colleagues in the World Bank. Back to you.
Great, thank you, James. And Patty, you led the People's Voice survey. You know how hard it is to get data, and the question to you as a researcher, as a former Minister of Health, is how do we get countries to integrate patient-reported measures into routine decision-making? And we're talking about, going beyond pilots. So this becomes, an integral part of quality improvement cycles.
It's almost 5 years using Zoom and you always forget to turn on the mic. Anyway, so thank you so much for that question. I think that's a $1 million, probably the $10 billion question, okay? So we need to keep pushing to understand at the level of the ministers of health how important is not only to measure, but to act on the numbers that we have, okay? Sometimes it's very difficult. And one of the difficulties is that you end up at the level of the government to so many commitments at the regional and the global level that you have so many indicators that you are trying to follow, and you don't know how to handle all of them. But I think there is hope, because there is also a new way at the level of the ministries and the new people that are getting into these positions, and they are trying and they are seeing quality in a different way, and I think that there is this big change on how we are seeing health systems. Is not only delivering services and counting numbers, is what people really it's experiencing. So that's why, I mean, you can see, and at least I think that is something that we really need at the level of the governments, and how we are educating and training the new generation of health providers. That is something that in which I think we need to invest. The other thing that we have been thinking about is the importance probably of starting to think about quality of health systems the same way we thought at some point, maybe 30, 40 years ago, about epidemiology, okay? When we were collecting data, but then we realized that it was not enough to collect data. We have to be intelligent about how do we use that data. So we may need to start thinking about the need of having these quality intelligent units, where we started thinking about the data that we are collecting from health systems and how we can integrate that and use that data to create changes, not pilots, changes that could be sustainable, together working. And that's another thing that is new, and we are breaking here the things that we were used to do, right? Involving the community, involving people, involving the patients, in these changes and these new designs of health systems. So I think it's a process, but I think we need to invest on changing the minds of health providers and whoever is going to be in at the level of making decisions at the government, and also maybe thinking about new ways of introducing these new indicators and changing the way things we are doing. So intelligent ways of introducing quality into the structure of health systems. I stop there.
Thank you, Patty. I think time has run out, but I wanted to finish on a very positive note. As I see how we've got a new window of opportunity, a new chapter that we can all write together. I mean, we clearly see the OECD as the lead on so many of these efforts, but clearly we can, leapfrog and leverage a lot of the work that has been done. And within the region, we've also had very good initiatives that we can also leverage. So with that, I'll pass it over to Seb for the closing, and thank you all very much.
Thanks so much, Javier, and thank you so much, everyone, for participating, and Javier for moderating the session and to guide this really interesting, important discussion. It's just the beginning, I presume, but given that we're only at 1 hour, we'll just consider this a start. So thank you so much. And before we close, we kindly ask you to scan the QR code on the screen to share your feedback about today's event. Your input is very valuable to us, so please do take a moment to fill this in. And with that, we've come to the end of the webinar. We hope this was interesting to you all and provided some useful perspectives. Thank you again to our presenter and our panelists for the reflections and this really interesting information. We look forward to seeing you all next time as we continue this conversation, as Javier noted. Thank you so much.
Thank you. Bye-bye.
Thank you. Bye-bye.